engaged with and outreach to and participated in those meetings on the next slide. We're currently now in a data synthesis and analysis phase, which runs December through March, where the Oliver Wyman team will use the data collected from the listening sessions, combined with relevant analysis of health systems claims and hospital discharge data to inform preliminary options and recommendations for hospitals. And the round 2 meetings will commence in the late spring, likely May, and run for several months. So what you're going to hear about today is findings from those discussions in the round 1. So we're in data synthesis and analysis, but the information you're going to hear about today is mostly the qualitative data that was gleaned through those interviews and community meetings. So we're really pleased with the numbers of people and organizations that were engaged. We had over 1,800 participants across all stakeholder types in these meetings. There's an average of 52 participants per community meeting, including the statewide meetings. There were 2 meetings held in each HSA. So all 14 HSAs had a community meeting for the community at large, and then another meeting targeted to providers. There are also additional, more targeted meetings going on at the same time, which Bruce and Elizabeth will talk with you about. There were over 100 organizations that were contacted through our outreach contact list. And to date, the count when this slide was put together was 93 or over 93 public comments, written public comments received. And I won't go through in detail the numbers here on the right, but this is just kind of one way we sliced up the different types of meetings to understand who we outreach to and how many participants there were in these different groups. And with that, I'll turn it over to Dr. Hamery.
Great. Thank you very much, Marissa. Mr. Chairman and members of the board, thank you for the opportunity to give you an update on our progress. Before we begin, I'd like to really thank the many Vermont healthcare providers, not only nurses, physicians, but EMTs, pharmacists, dentists, and many others for taking time out of their evenings after a very busy day to offer their experience and advice. We also need to thank the many Vermonters who took time out of their days to share their lived experiences with seeking, obtaining, and using healthcare in the state. During this effort, as Marissa noted, we've also had the chance to talk to the leadership and board members for each of Vermont's hospitals. Without exception, they were a professional and knowledgeable group of people doing the best they can to serve their communities while working within a very dysfunctional health system. The participation of Mr. Mike Fisher, the state healthcare advocate, in many of these community and provider meetings was invaluable. And certainly, last but not least, I need to thank Marissa and her group who have helped to guide my team through the complexities of the various state agencies and healthcare organizations in the state, as well as the groups and representatives of the groups experiencing health inequity. So let's go to the next slide. Marissa. So we'll talk briefly about the goals, spend a lot of time on the work completed to date with the preliminary findings. And just to reemphasize Marissa's point, these are entirely based on comments made during one or more of these meetings. They are representative comments. They're not, we obviously can't include them all, but they do reflect the themes that are involved. Next slide. Okay, so we were asked or directed to develop and conduct a process that was data informed, patient focused, and community inclusive. To the data informed part, thus far, we have reviewed as many of the prior consultant reports to the Green Mountain Board and other state agencies, including those on workforce and mental health. Reviewed the Vermont State Health Plan, the various community health needs assessments for each of the hospitals, and so forth. We've also reviewed data made available through the Green Mountain Care Board, including the hospital budget submissions, the VCures data, and so forth. I think Marissa has expressed to you the extent of our patient-focused and community-inclusive efforts, which I think have been as complete as time and availability of those groups could be. We have been asked to produce some outputs from this process. And remember, we are only partway through it. And those goals were to reduce inefficiencies in the hospitals, to lower their costs, and I would say constrain cost growth, improve population health outcomes, reduce health inequities, and increase access to essential services. And so we're going to start with going through one by one the 9 essential community health services listed by the American Hospital Association. We'll then go to the diversity and inequity issues and to some of the financial considerations. Next slide. Okay, so the first one is access to primary care, subject to a lot of discussion over the last few hours. Each slide starts with some representative comments from some of the participants. You'll note the second one here, no one is taking new patients. There's a 1-year waiting list for new patients. We've heard other numbers up to 18 months. So there is a shortage, and as noted previously, practitioners are aging and retiring. And there is a lot of concern on the part of the provider community about their inability to help patients get care. And we'll come back to that in some other areas. And so that is causing what is called moral injury. That is, you feel devastated that you can't get your patient to an appropriate specialist or hospital to get the care they urgently need. There's also a shortage of advanced practice clinicians. No in-state training for PAs, and not a master's level program for advanced practice nurses. Somewhat lengthy training for doctors of nursing practice to get a clinical certification, but very importantly for all of the state efforts to educate medical assistants, RNs, and others, there is a shortage of both instructors and clinical sites. And that also nationally is a major roadblock to producing more of these needed people. There is another feature in primary care, and indeed for most of all the physicians, and that is that administrative complexity reduces their clinical time available. One of the quotes from a practicing doc is he or she said, "I spend at least 2 hours a day doing prior authorization and pre-cert and arguing with insurance companies and state agencies about things." And if you consider that a doctor in those 2 hours could have seen either 4 or 6 more patients, That means they could have had somewhere over the course of a year between 700 and 1,000 additional patient visits. So this is a matter that might be corrected in fairly short time and have some impact on access. Another is the cost of this. Another physician noted that his office has had to hire 4 support staff for each clinician in order to handle the paperwork and all the other things that they are responsible for. In addition, everyone's experiencing difficulty in recruiting new professionals to the state. A lot of it has to do with housing, and we have heard reports about advanced practice people sign on the dotted line, come to work, spend 3 to 6 months in a hotel because they couldn't get housing, and then they left and went out of state. Additional issues, lack of childcare, poor support for elderly relatives, and relatively low pay, at least as perceived by those reporting. So this is a data point we need to validate. Next slide. Okay, psychiatric and substance use treatment. One mental health advocate noted that an emergency room is not the place for mental health care, and people who have mental health issues give up after they go to an ED and are treated as though they have a physical ailment rather than a mental health issue. There is a shortage of psychiatrists and mental health professionals. Had several instances cited of psychiatrists and others leaving for better paying jobs elsewhere. There have been comments, many, about very relatively severe difficulties in having licensed clinical social workers and other mental health professionals who are licensed and have practiced in other states, and their ability to obtain an unrestricted license in Vermont. This was noted in a mental health report, but the mental health group was given 5 years to fix this. Shortage of mental health beds for acute and chronic needs, 194 beds available roughly in the state, and 23 additional for children. And this is a quote from a state official. I would note that of those beds, 30 are now closed for renovation and other things. And at another hospital, they have 14, but they are double rooms. And so typically they said they can only serve 8 to 9 patients because they have to, of course, put men with men, women with women, and at least reasonably similar diagnoses. So shortage, and another issue other than lack of inpatient, which causes boarding, is lack of intensive outpatient treatment and daycare services, lack of group housing for appropriate patients. We talked to one community where they had just gotten permission to build group housing. It took 5 years to get through the regulatory processes. Difficulty in finding transport for suicidal patients. The police cannot take them, so they require an ambulance to go, and ambulances, as we'll hear about, are in short supply. And lack of appropriate facilities in emergency departments for acutely ill mental health patients. Next slide. Emergency and observation services, key point for avoidable hospital use. One of the ED directors, and we spoke with most around the state, not all, this person said many patients that are labeled avoidable actually must be seen. They come from skilled nursing facilities, police, social service agencies and others, and they have nowhere else to go. The hospital is in a sense, the court of last resort. As noted in the prior set of discussions, a recent estimate by another consulting group a couple of years ago was that 30% of ED visits were potentially preventable by ready availability of primary care or community-based mental health services. However, those EDs are often crowded and holding patients who need to be transferred for another level of care, either to another hospital or to a mental health facility, or they're unable to go home. One hospital reported a need to use 8 beds in their ED out of, I think it was 15, to board inpatients awaiting transfer. And this was not an uncommon report. Another hospital reported opening 12 new ED beds and having 8 of those occupied by people who were being boarded within 4 weeks. So an urgent matter. Observation beds are also commonly used for boarding, and specialty coverage for ED patients where people could get advice, perhaps take care of the patient in the local hospital and then send them home is difficult. Specialty coverage. Telehealth is is helpful and is used by some hospitals. Others have reported it is too expensive for them to afford. Next slide. Okay, prenatal care. We did not, in the general community comments, have any mention of inadequate prenatal care. I'll turn it over to Ms. Sutherland in a minute for the diversity issues. But I would say the review of the state vital records, which report the prenatal care that women receive by month prior to delivery, suggests that generally prenatal care is available and used. There are exceptions for women under the age of 20, certainly. Elizabeth, do you care to comment on these other 2 points?
Yeah, I think the only thing I would just call out, and can you guys hear me? Okay. Hi, everyone. I think the only things that I would just call out is that while the data isn't there, and you'll hear this theme later, there should still likely be effort into try to understand why why there is this variation. It's not something that the rest of the United States isn't experiencing, but it is something that is impacting those that we've interviewed, not from a personal standpoint, but from their opinions on where they would go to have and receive childcare. And then this final bullet here, I think, is similar to the transportation barriers or gaps or challenges that we've heard across other services, is that, you know, UVM's great, others facilities are great, but the wraparound services provided when you're 2 hours, 6 hours, 8 hours away from your home doesn't seem to be thought through, particularly when going to the NICU. And so it's kind of just like moving and transferring, and the family will figure it out themselves for how they're going to get there. And by nature of the state, that's kind of the situation we're in, but it's a challenge. And so you'll hear that theme too in a couple other transportation areas. But
Right, thank you. Next slide. Okay, transportation is a huge issue. It is not only an issue of inequity in terms of access and availability, it is also having a major impact on the efficiency and effectiveness of the hospitals and the care providers in the state. One of the local care providers noted that in their area, almost 20% of patients did not have a car. And this was a rural area. Another community member said ambulance service is critically important, and there is not enough ambulances to go around, which increases wait times. for getting service, and as we have noted from ED people, getting between hospitals. So personal transportation is often lacking. Inability to afford the gas, if money for gas, if you have to travel, and hospitals are often supporting this with coupons and things. Public transportation may not be available when needed. The movers that are used for Medicare patients and others are available only during work hours and need to be scheduled 48 hours ahead. So, of course, if you have an urgent issue, need to get to the doctor's office, primary care office, or ED, it's not, that service is not available to you. Bus routes may not connect together well, as we've heard, and we've heard routinely that patients who are taken to the emergency room by an EMS service, that transportation is paid for only if medically necessary. So it's medically necessary on the way to the hospital. It's not on the way home. So there's no transport for the patient at midnight when the ED says you can go home to get them home, and the patient winds up sleeping overnight in the emergency room waiting area in many instances. Availability of EMS transportation for inter-hospital transfers, I apologize for the typo, is sporadic. And we've heard stories of people calling 19 or more different EMS services to find an ambulance crew that is able to take a patient somewhere. One EMS service, actually 31 was the max. One EMS service reported spending a number of hours with the patient in their ambulance, waiting to take the patient into the emergency room because the emergency room was full. So this is at all levels. Patients often need to travel long distances. We heard from one gentleman whose spouse had a significant healthcare problem. They had to go to a major medical center, and he reported that within a year they spent $5,000 for hotel costs and transportation costs, and traveled roughly 8,000 round trip miles to get care. So, as Elizabeth noted earlier, in a rural area, access to certain services is very difficult, and a lot of that cost falls on the person, certainly not on the system. Next slide. Diagnostic services. Timely access to have your issue diagnosed. One physician noted that in their local area, there was a 6-month wait time for a colonoscopy. Colonoscopy obviously being a recommended preventive service. And so this issue is something we'll look at in terms of how well is it done? What are the potential numbers of people who maybe don't have access to this? Specialized diagnostic equipment, for example, for pulmonary function tests, is often not available in the smaller hospitals. Population may be too small to support it. There is a universal problem having the technical help to actually administer the test, and that's true across all the sizes of hospitals and nationally, by the way. Hospitals are dealing with this by trying to jointly hire or share both the specialist and acquire the equipment needed to do these tests in rural areas. Access to certain specialty services and tests at the 2 major referral centers, Dartmouth and UVM, are limited, and particularly for non-emergent care. Timely access to interventional cardiology. Again, we've heard stories of patients with what's called a STEMI, which is an indication of acute myocardial infarct in one of the major arteries of the heart, being placed in an ambulance and sent 5 hours to a hospital that could do that procedure. The standard of care nationally is 1 hour. So medically unacceptable. Patients with unstable angina who should have a rapid evaluation because of shortages in equipment availability have sometimes had to wait 3 or more days to get that intervention. Problems that are common to all hospitals, including the 2 major referral centers, include lack of enough specialists, a shortage of technicians, as I've noted, and obtaining timely pre-certification for testing and treatment. I note that Congress acted, I think, CMS acted today to tighten that up for Medicare beneficiaries. Next slide. Home care. Home health agencies have had to reduce their services because of a lack of staff. They can't compete for wages with the hospitals and other employers, and that is based in part on poor reimbursement. And so several of all the nursing home health agency people that we spoke with cited that as a problem. Next slide. Dentistry, again, a major problem. And a community member just said, look, many doors are slammed because dental providers won't accept Medicaid. And this is in spite of the fact, as Mr. Fisher pointed out in some of the meetings, that the state has recently raised rates to pay dentists for Medicare or Medicaid beneficiaries. That was done, I think, in last July, maybe a little early to estimate that impact. It's a statewide problem. It is particularly severe for children and Medicaid patients. The lack of preventive dental care clearly shows up in the potentially preventable ED visits. And I would note that when major dental work is needed for children, they often have to be put to sleep. They have to undergo major anesthesia, which is a health risk and not available in all hospitals. Pediatric anesthesia, particularly for small children, is a specialized service. Next slide. Okay, robust referral structure. Can you get a patient to a specialist when they are needed? And primary care doc just said, can't find specialists for my patients now. It's functioning very poorly. This is not a change from work that the state did with some of my group a year and a half ago. Shortages of virtually all specialists at UVM and Dartmouth, long wait times for routine services. Usually they can meet emergent needs, although there are a number of instances where patients have had to be transferred to Boston, Portland, Maine, New York City, large hospitals in Connecticut to receive those specialty inpatient services. Recruitment of all medical and surgical specialists is a problem statewide and at Dartmouth. Communication from the specialty groups back to the primary care providers is poor. We've heard a number of comments. The State Health Information Exchange is intended to help rectify this. It's still under development. The primary care folks have said does not deliver accurate medication lists or a list of currently active diagnoses, that they'll get a list of 30 diagnoses and they can't tell which ones the patient really has in the near term, and that the med lists are often well out of date and represent drugs that the patient is not on. So the lab results are much better, but with those other two elements lacking, timely decisions about treatment are difficult. Note the hospitals and the physicians are on a number of different EMRs, and they're really dependent on the health information exchange to connect with one another and transfer information. Same issue with getting consultation notes from specialists. And an additional note about the OneCare was not considered by the docs to be timely in getting the information they needed to provide care to patients. So getting a list of who has diabetes, who am I trying to take care for, trying to take care of for those preventable issues was not considered to be good. A complicating issue with all of this, which really impacts specialty availability, is that the specialists say, look, I take a patient who has diabetes, has epilepsy, I get them stable. They are on meds, they can go back to their primary care doc, but the primary care doc can't see them. He doesn't have room. Or the advanced practice person feels uncomfortable. So the result is the patient keeps coming back to the specialty clinic, which means that new patients don't have access. Next slide. Okay, costs. Well, as you've heard, costs are universally considered to be too high. A lot of opinions about why this is: high hospital costs, poor access to early treatment and preventive care, resulting in patients with more advanced and severe, thus costly disease. Number of the emergency room physicians and specialists commented on that. Repetition of tests, and that was commented on by both patients and physicians. And then the widely held view that both hospitals and insurance companies have a profit motive and want to drive volume. Hospital costs, clearly, as the board has already heard from its budget hearings, staffing costs are huge. There are increased costs of employment, getting employees and retaining employees because of national shortages, use of travelers to fill in nursing vacancies and various technical areas, and the use of essentially travelers, locum tenens, by hospitals to staff certain physician services, or the use of telehealth with attendant high costs. That is, the person providing the telehealth charges the hospital more than the hospital is going to get reimbursed for. And then on the hospital part, the 340B funding, the federal drug program, has been reduced. That often accounted for a significant part of the hospital's excess of revenue over expense. Next slide. Okay, Elizabeth.
All right, thanks. So just rounding out some of the observations, wanted to dive a little bit more deeply into some of the barriers to health equity that were being experienced by typically marginalized or smaller populations. And so to get started, we worked with kind of the list to the left as our guiding principle for those that we wanted to engage, reach out to, hear from either directly or a representative in areas where we weren't able to connect in person, because of language, especially because of language barriers. And so big thank you to many folks on the line here for helping kind of stitch together the different groups across the state to get in touch with these, to get in touch with perspectives and hear perspectives from the groups on the left. Through about 30 targeted interviews, about half of those were with smaller groups, and then the other half coming from community sessions. We identified 3 kind of trends in terms of areas for improvement. There were bright spots that we heard. I know that the focus here is really where's the opportunity of this presentation. We definitely did hear some bright spots around different HSAs, providing access and providing coordination for members of the groups to the left. But this is homing in on what we heard as areas that recommend attention, prioritize attention to decrease the health equity barriers for these groups. And so those 3 areas are around culturally competent care, culturally competent and psychologically safe working environment, so the patients and the employees, and then coordination with caregivers and community services. And so just diving into the first one around culturally competent care, a couple areas, obviously there is a large, as we mentioned before, I think on the prior speaker, the rurality and then the economically disadvantaged is a large number of people, and they have a different experience with the medical system than those that are not economically disadvantaged and in very rural areas. And I think one of the things that we noticed, and this is, I would say, coming more from the working environment, is that when we would bring up the term health equity with groups that were speaking to leaders, it really was kind of all about race and ethnicity. And it didn't seem like that, thinking kind of beyond race and ethnicity for health equity reasons was something that was part of the typical conversations. And so that's why we're kind of coming at this as the cultural competence here, in that while there are a small amount of non-English speakers, they do exist. They exist and they're growing within Vermont. And so translation and interpretation resources was a big gap. There's a lot of kudos given to the Language Justice project, but they are not they're not able to reach everyone, and also not quite available at all times within the hospitals. I see a hand up. Owen, do you want me to pause real quick?
I had 2 questions on the boxes in the bottom. I just wanted to clarify and make sure I understood it correctly. So the ones that say hospital exec, does that actually mean an executive, a C-suite level person from a hospital?
Yes.
Okay. And then one I just didn't quite understand. Everyone in Vermont has a snowplow. What is that supposed to mean?
Kind of in on that first double click bullet point here, when we're bringing up how are you thinking about caring for those that, have tough time getting to your services during inclement weather. That was the response.
Okay. All right. Sorry to interrupt. I just wanted to clarify.
No,
thanks.
Please. Yep, absolutely. And putting it there because I think it's, some of this stuff is, I can see that good to talk about. It's good to bring this up because I think that this highlights the areas where some cultural competence training for staff about how they're working with patients, and then how they're also, we move into the next one, I think here, about the just psychologically safe work environment. I haven't done walkthroughs of the hospitals yet, but what I've heard is that there are in some places you might find policies front and center around zero tolerance for hate towards workforce. Heard a couple stories that folks, when clinicians do experience racist comments or hateful comments, it's the typical kind of responses, well, we'll just give them someone else to care for. And while I know that, everyone deserves care, at the same time, there are some rules and ways in which we can make our employees feel a little bit more psychologically safe as they're performing this job on the front lines. And then I think the last of the lack of coordination with caregivers here, the patients with the needs that are best served outside of the hospital, as we mentioned before, particularly around mental health, substance abuse, housing challenged, and other SDOH issues, they are driving up ED utilization. And so working to coordinate the community services that can support these needs can decrease your ED utilization if that coordination is run a little bit better. And then the admin resource is also something to call out here, required for patients in the community health nurse programs to have access to Medicaid or getting coverage for certain things, or the payments covering, the reimbursements covering those working at the nursing homes, or what to sit in a room with a patient while they're doing telehealth just isn't sustainable from a cost perspective. And so I'd say that this is kind of our three main areas of observation for where there's opportunity to improve the health equity, equitable access for these diverse populations, but also kind of for all Vermonters as well. Anything to add, Bruce?
Well, as you said, there are some bright spots here and in some of these other areas, and we'll get to those in the phase of thinking about what potential solutions are. Some are reasonably quick. For example, signage, right? One of the things that we heard is, boy, if your language is other than English, you can't understand the bill you get from the hospital. You don't know that there are interpretive services available, or that someone will assist you in applying for financial relief from the hospital. So some of those things could be fixed in a couple months. Other things will require a lot more effort. Let's go next slide. Okay, so just a thought here, because we've listed a lot of problems, and you heard an extensive discussion about global payments, population-based payments. I've been in that for 30 years and helped people set them up. These are the things that you really need to think about to make that successful, to optimize your chances. One is tight alignment of financial incentives among all participants. And one of the things that the hospital and some of the primary care folks noted in the discussions was those incentives are not aligned. Critical access hospitals get paid 101% of Medicare based on their fee for service. The federally qualified health centers get paid based on their prior year's budget. And so they are also incented to, send care elsewhere if they don't have it in their budget, or, to get help doing certain things from the hospital. Sharing of adequate and timely clinical information. The biggest immediate saving in any population health matter is caring for the chronically and multiply ill. The preventive services are important, but they take time to pay off. Rick Gilfillan, who was the first head of the Medicare Center for Innovation, taught me that. You need adequate resources for primary care, mental health, and preventive service in the community, as we've talked. Availability of referrals so that you can get expert help, and appropriate levels of care other than expensive inpatient beds, and covered by the previous session as well. I'll note that the availability of tertiary and other services to support those local hospitals is needed. Also note that currently a lot of that is provided out of state. And just as an example, if someone goes for cancer care to Dana-Farber, the Medicare payment for inpatient services is 42% higher than it will be at UVM. And for ambulatory services, it's 37% higher. A GAO report on that about 7 years ago. Next slide. Okay, so where are we? We are awaiting the availability and validation of the 2022 hospital discharge data, because as we think about what options are for improving services and efficiency and effectiveness in hospitals, we want to use the most current data, and certainly nothing that is well within COVID or prior to COVID. We are having another consulting group. It's a different part of Mathematica, and we're delighted to have them to work with. And we are looking at these sorts of issues. The number of dual eligible individuals, those getting eligible for both Medicare and Medicaid in each service area, because special attention to those groups can significantly reduce costs. We're looking at the total volumes, both inpatient and outpatient, of certain surgical procedures at each hospital. The volumes are important measures of quality. If there is data on 13 or 14 of these, including in critical access hospitals, that if you're below a certain volume, the complication rates go up. And the physicians in these groups that we've spoken with agree with that. We're looking at volumes of potentially avoidable ED visits, hospital admissions, what those diagnoses are, what alternatives to current primary care services could be made available to help reduce those numbers. Estimate shortfalls in care by looking at mammography and colonoscopy rates as measures of things that are readily available at a population level. Look at the number of people leaving Vermont, which are dollars leaving the state, for care that could be provided in Vermont. And just as an example, there are instances, which we'll quantitate, of people being sent from Vermont to a small hospital, not Dartmouth, but a small hospital in New Hampshire. And if you send them to a 30-bed hospital in New Hampshire, certainly the treatment of that pneumonia, whatever, could be done in Vermont were capacity available. So we're in the process now of taking this information that we've presented, the reports that have been done, the data that is being analyzed and will be available, and then devising potential solutions. And I think there are some. The difficulty is the major ones are going to take time to really come to fruition. And so we'll then formulate those and then have those hypotheses analyzed for their potential impact. I've begun to schedule visits, personal visits to each of the hospitals, and we'll get those conducted over the next probably 2.5 months. So, but I intend to go up, meet with the hospital leader, tour the hospital, ask some questions, meet some of the other folk, and really look at the ground. After we have the hypotheses formulated and tested, and we're going to try to predict the effect of these things on access to care, the hospital finances and sustainability, and potential to improve equity. We will do this, however, in a fee-for-service world, in the current world. The questions that were asked earlier about what will this look like in a global payment is in the purview of the Mathematica group and the experts you heard from earlier. Next slide. All right, and then in May and June, we'll get to meetings in person with a joint session of the hospital leadership team and their board to present what the options might be and get their feedback. And we will also do that in a separate in-person meeting, town meeting style, in each hospital service area for the community members to get their feedback and any additional suggestions. And then after that, we'll reformulate those options and then bring that to the Green Mountain Care Board as a set of options and recommendations. So, Mr. Chairman, that concludes our presentation. We're happy to entertain questions.
Well, thank you both very much. It was extremely informative. I'll open up to the board members. Why don't we start with members Lunge and Walsh first? If they have anything, they can take the floor first.
This is Tom. Thanks for the presentation, very informative. I don't have any questions at this time.
I have a question, but I don't think it needs to be answered today, but I'll just throw it out there. I'd be interested in understanding the assumptions that go into the fee-for-service world, because as was discussed earlier, we're currently in an all-payer model world, not a true Medicare fee-for-service world. So I'd be just interested in more detail on those when that's available.
Yep. Thanks for the clarification, Robin. I misspoke. It'll be the current environment, right? Thank you.
That's it for me. Thanks.
I just had one. So your report will have things that hospital systems can do now and identify some gaps and opportunities. Is a part of your report also identifying strategies that the state can think about that's outside of the hospitals, or is it just particular to the hospitals?
No, sir. Thank you for that question. And I should have said that. We would anticipate several levels of recommendations. One certainly would be for the local hospital. The other would be to your group and the state for changes in, for example, EMS services, or the way that certain people might be paid, or the information system, whatever, that would require either a legislative or a regulatory change. And I would also say the third level would be potential changes in some of the federal things that you might either consider negotiating for as you think about a new payment model, or refer to your senators and congressional folk for their help.
Great, thank you. I don't have any other questions. It looks like Member Holmes is all set. So I will open it up to public comment via the raise the hand function. And I'll start with the healthcare advocate and Mr. Schultheis.
Well, I'll just keep this very brief because I'm looking at the time and I'm sure everyone has to get out. Mr. Hamre, Dr. Hamre, and Ms. Sutherland. So our office has been working on one of the low-hanging fruits you mentioned. So the stuff around the patient financial assistance, that comes from a bill that VAWS and the HCA championed the other, 2 years ago now. So you might want to call Mike, Dr. Henry, because our efforts along those around plain language and notice is actually pretty well developed, as is a rollout plan. And that was meant, those minimum standards were meant to make things around language access and some other things a little bit clearer than the rather vague IRS regulations. Thank you.
Right. So, yep. Thank you. We will certainly get back to you guys, but remember, these are comments that reflect the experience of the already another group. So it may be older experience, but certainly what we heard.
Oh, it hasn't been implemented at all yet. I'm just telling you that that low-hanging fruit is being grabbed.
Great, great to hear. Thank you.
And thank you, Eric. And I failed to mention earlier that how helpful Mike and the healthcare advocate group has been. So that was been really helpful as we have attended many of our meetings, provided real-time guidance to those that were asking questions about things and sharing experiences. So just sorry for not saying thank you earlier, but very much appreciate it.
Thank you so much.
Any other public comment? Okay, great. Well, thank you, Dr. Hamre and Ms. Sutherland and Marissa and Hillary. I really feel like this has been a bright spot of our work in the last year. We've learned a lot. Those meetings went exceptionally well. We all attended many of them, and it was a really robust discussion, and this is extremely informative. So thank you. This is really important work.
Thank you.
Thank you.
We'll look forward to the coming months. Okay, I think that concludes our agenda today. Is there a motion to adjourn?
So moved.
Second.
Okay, and all those in favor say aye.
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 Aye. And the motion carries, and we are adjourned. Everyone have a nice day, and I hope you get to enjoy our delayed but wonderful snow. Thank you.